Hello, my name is Thor Halfdanarson. I am a professor of medical oncology at the Mayo Clinic in Rochester, and I specialize in neuroendocrine tumors and their management. I would like to thank Elise for the introduction and the NET Research Foundation for inviting me to speak at the conference this year. So I we'll be discussing some general topics in the management of neuroendocrine neoplasms, and these are my disclosures. This is a list of the objectives for the talk. So as you can see there, we'll talk a little bit about what neuroendocrine neoplasms are, how common they are, a bit about grade and stage, then grade 3 neuroendocrine neoplasms, and then lastly life expectancy. So let's start with the basics. So what are neuroendocrine neoplasms, or NENs? So, well, NENs is a relatively new term which we're increasingly using now. And we can still use the NETs, and as a matter of fact, I usually go back to calling them NETs. So neuroendocrine neoplasms, or NENs, stands for, as you can see, neuroendocrine neoplasm, but then we also frequently talk about NETs, neuroendocrine tumors, and the neuroendocrine carcinomas. So the neoplasm term is really just an all-inclusive term for tumors. It's essentially a normal mass of tissue that results when cells divide more than they should, or they don't die when they should. The definition of a tumor is essentially the same, but for the neuroendocrine tumors, actually, there are subtle differences there in the definitions. As for neuroendocrine carcinoma, the carcinoma generally means a more aggressive process, more invasive, more likely to metastasize. So let's talk about some of those definitions. So NENs, or neuroendocrine neoplasms, or malignancies, or cancers that can arise anywhere in the body, essentially, but most commonly in the small intestines, the lungs, pancreas, and the rectum. And neuroendocrine neoplasms, or NENs, are a very heterogeneous group of cancers, so they differ from one person to another. I often say that no two neuroendocrine tumor patients or neuroendocrine neoplasm patients are the same, because they can present in such a variety of ways. So how common are NETs? And as you can see now, I'm gravitating back to calling these NETs because that's what I've been doing for the last 10 or 15 years. So for the remainder of the talk, I'll probably use the term NETs more than the term NENs. Well, so the number of new NET cases is rising. So on the left-hand side here, you can see that the incidence, that is the number of new cases per 100,000 of population, is about 7 for all sites, or all anatomical sites, and about half of them roughly are from the intestinal tract. So just a little bit about the incidence. So essentially it's a number of new cases over a certain period of time, often expressed as the number of new cases per 100,000 people. So I explain this often to my patients living in Rochester, which is a town of about 100,000. That essentially is the number of patients I would expect, or number of new cases in a community like that. So the median age at diagnosis is 63 years. And as I've been giving this talk in person in the past in Illinois, I calculated it might be about 900 cases per year in the state of Illinois. And as I said, mostly seen in the lung, small bowel, pancreas, rectum, and the appendix. Well, if we look at the graph here, if you look at the blue line that's sort of on the top there, this is the number of new cancer cases since the early 70s until 2012. And as you can see, in the 80s and 90s, there was an increase in the number of new cases of all cancers. So now we're talking all cancers. But then we've seen a little bit of a decrease in the number of cancers in recent years, probably because of better sort of lifestyle choices, less smoking, but also probably because of more screening for cancers like colon cancer. Well, if you look at the yellow line, these are the NETs, and these are drawn to a very different scale. There's an almost 100-fold difference between these scales. So I'm not saying that the NETs are no more common than all other cancers combined, but what I wanted to show here is the increase in the number of new NET cases over the last few decades. You can see that there has been a substantial increase, and it continues to this day. And we think some of this is just because we're getting better at diagnosing NETs. We might have called them something different in the past, but I think there's also a real increase, and we can't explain why that is. We just don't know why. So to me, as a neuroendocrine tumor researcher, This is one of the most puzzling things about NETs. Why are they becoming more common? So let's talk very briefly about a term called prevalence. So the incidence I mentioned before is the number of new cases in a certain population over a certain period of time. So essentially how many new cases are being seen. The prevalence is actually how many patients with NETs are living at a particular time point. So even if you have a rare cancer, but people with the cancer live for a long time, you keep adding to the pool of cancer patients, but most patients live for a long time. So we always add to the pool. Not many people fall out of the pool. So the number of persons living with that particular cancer at any given time is pretty high, actually much higher than the incidence would suggest. So the incidence increase or the increase of new cases is seen across all types of NETs. So here you see the lung NETs. You can see since the 70s until till 2012, there has been an increase. For the small bowel neuroendocrine tumors, there's certainly an increase as well, and probably most notably for pancreatic NETs. As you can see, that gray line that in recent years has just taken a sharp turn upwards, suggesting that we're diagnosing a lot more than we've done in the past. And I think a lot of this is that we're just doing more scans and we're picking up tumors that we would otherwise not have known about. So these are patients who come in to the emergency room with abdominal pain. They have a CT and they get a scan and a tumor is found. So let's talk a little bit about grade and differentiation, because these are very common terms and they're often confused with each other, and they are related but not the same. So the behavior of NETs varies greatly from one person to the next. These can be super slow growing tumors or they can be very fast growing tumors. And the two things that determine the aggressiveness or the behavior of the tumor are the differentiation and the tumor grade. So grade 1 tumors tend to be very slow, while grade 3 tumors can be extremely fast growing. But even within each group, there are substantial differences. So this is going to be my most busy slide. I'm not going to test you on this at the end of the talk. I just wanted to call out this current classification of neuroendocrine tumors. Now we see that there are 6 different classes. So, and if you look at the top table there are 3 groups of neuroendocrine tumors, well-differentiated neuroendocrine tumors, and we differentiate them, or we tell them apart by what's called the Ki-67 index. I'll talk about that here in a second. Then there are 2 groups of neuroendocrine carcinomas. These are poorly differentiated, high-grade tumors. And then there's a category of mixed tumors, which we will not talk about. But really the key here is that we can have well-differentiated tumors that are grade 1, grade 2, or grade 3. They tend to be better behaved. We can have poorly differentiated tumors, which typically are aggressive, and they are all grade 3. So a little bit more about the tumor grade. So it's a system to predict how fast cancers will grow and spread. And we use a stain, a tissue stain called Ki-67, sometimes called MIP1, that determines the grade. So this stain only stains cells that are actively dividing and does not stain cells that are resting. So the more dividing cells you have, the more stain there's going to be, and the more aggressive the tumor is going to behave. So the way this looks to the pathologist is like this. So on the left-hand side, you have a grade 1 tumor. You have a lot of blue little cells around blue cells. These are resting cells. They are not dividing. You see a few brown dots in the middle. Those are the positive cells. In the middle panel there, we have grade 2. You can see a lot more brown dots. And on the right-hand side, you can see pretty much nothing but brown dots. So this is a very active tumor. Most of the cells are actively growing. So as for the grade 3 neuroendocrine neoplasms, they are not all the same. So some of them are neuroendocrine tumors, well differentiated, expected to behave better. Some of them are carcinomas or NECs, NECs, and they are expected to be more aggressive. And this distinction really requires expert pathology. So here we need a pathologist who is very used to looking at these tumors in the microscope. So what is the differentiation then? How is that different from the grade? Well, the differentiation is actually how much does the cancer resemble the normal cells that it originated from? And this is where we need the trained eye of the pathologist. Does it look quiet and well-behaved, well-differentiated, or does it look aggressive or poorly differentiated? And so those are angry looking cells, all of different sizes and shapes, and they tend to be more aggressive. And we can have the well-differentiated tumors, and we can have the poorly differentiated tumors behaving in a very different fashion. So all poorly differentiated tumors are grade 3. Not all grade 3 tumors are poorly differentiated. So that probably is the most important thing with the grade 3s. So next, moving on to stage. So the stage is probably the most important determinant of prognosis. So we can have a stage 0, which we almost never see. Stage 1 is localized small tumors, just limited to the organ. They started in stage 2, slightly larger tumors. Stage 3, typically into some lymph nodes. And stage 4, when the tumors have gone to different parts of the body. And let me walk you through stage 1 through 4. So stage 1 and stage 2 are actually limited to the organ of origin and have not gone to any lymph nodes or other parts of the body. Stage 3, typically involvement of lymph nodes nearby the organ this all started in. And then stage 4, now the tumors have left the organ they started in, have moved into the liver or even into the lungs or bones or other parts of the body. So that's stage 4. So moving on to life expectancy of patients with neuroendocrine neoplasms or NEMs. So this is a sensitive topic because no one really wants to talk about life expectancy. And what I want to tell you is that we need to factor in a lot of different things. And the numbers I'm going to talk about are average numbers that don't necessarily apply to individuals. But these are some sort of general terms. So the things that determine survival, as we talked about, tumor grade, tumor differentiation, and tumor stage. So these are incredibly important predictors of survival. Then we have other incredibly important predictors, including the presence of other serious illnesses. Let's say if someone is already fighting severe congestive heart failure or a neurological condition, they may have a short survival, but it's not necessarily from the tumor itself. And then obviously the willingness or ability to receive treatment, and then also access to care. And that is something that we will not talk about, but that's something that probably should be studied better and should be discussed more, is that not all patients have the same access to care. And the survival numbers typically come from studies looking at large group of patients, as I talked about before. So let me explain to you the median overall survival concept. And we can also talk about this as a median survival or just a median number, and I'll walk you through some examples. So this is one of the most commonly reported survival number. So again, an average number for a group of people, and we look at people with a given disease and we see how long they live on average. This does not apply to individuals. So this is defined as the time from diagnosis or start of therapy or whatever time point we want to look at until half of the patients have died. And died of any cause, so not just a cancer, but also of other causes, heart attacks and strokes and accidents and other things. So it doesn't always tell us about the death secondary to the cancer itself. Be very careful when you interpret this to individuals and explain it well, because a lot of things can actually play into this number. So this is an attempt to try to explain this a little bit better in a graph. So on the x-axis there, we have time. On the y-axis, the vertical axis, we have the percentage of patients living. And let's say we start with 24 patients. So 100%, they're all alive at the time 0 at the beginning. And then at some time point in the future, half of them have died of whatever cause. And then we draw a line through this, and the lines are never that clear and smooth. And we see that the number of living patients over time is decreasing. And if we draw a line from 50% on the horizontal or on the vertical axis, and as that intersects with the line, the brown or the red line there, and then we draw a line down to the time axis, then we get the median survival. So the time frame there, the arrow there, is actually the median survival time. So this is how we calculate this number. But we can apply median numbers to other things. It doesn't have to be applied to the time until someone dies. It can be applied to the time from start to treatment until the tumors are growing. It can look at the time from surgery until a tumor comes back, and a lot of other things. So a little bit easier term to explain is the 5-year overall survival. So this is to look at how many are alive at a given time point. So 5-year survival is commonly used. So think about 100 hypothetical patients. They're all diagnosed with the same disease on the same day. And we're exactly looking at how many of them are alive 5 years from the diagnosis. And that's, so if, let's say if I had 100 patients like this in my office that same day, and they would say, well, come back in 5 years and I'm going to count how many are still alive. And that's the 5-year survival. We can look at 1 year, 2 years, 10 years, but 5 years is very commonly used. So this is a median overall survival of some neuroendocrine tumors. And these are numbers from a large database in the US. So be careful interpreting this. I'm going to point out a few things. So this green arrow looks at the appendiceal tumors, localized or lymph node positive. And you can see survival is beyond 350 months. We're talking a long survival. Essentially, almost no one ever dies from a localized localized appendiceal neuroendocrine tumor. If we look at pancreatic neuroendocrine tumors, you can see that even for lymph node positive disease, there is substantial risk of dying even within 10 years. And for those with metastatic disease, in this data set, the average survival is only about 2 to 4 years. But we know that this is from a large data set, and actually the numbers are actually better than this. And lastly, these are the numbers for small bowel neuroendocrine tumors. You can see, and these are all median overall survival numbers, so the survival time is on the y-axis to the left there. And you can see that for metastatic small bowel neuroendocrine tumor, the average survival is probably somewhere between 50 and 100 months, so less than 10 years. But we know actually in recent years, it's probably much better than that. On the bottom part there, I just wanted to point out to you those very, very small columns. You see those 3 columns together. So one of them is like dark, and there's lighter colored, and then there is a color in between. So the column to the right is the grade 3 and grade 4 tumors. And you can see there that most patients with grade 3 and grade 4 tumors have a very short survival. And we'll talk about that a little bit in the next few slides. Let me first show you an example of a long median overall survival. This is for what's called typical low-grade lung carcinoid tumor, low-grade neuroendocrine tumor of the lung. And this is looking at survival time after surgery. So if you draw a line down to the 5 years, on the horizontal axis, you see the survival time. And if you look at the 5 years, you see that at 5 years after complete surgery, 93% of the patients are still alive. If you do no surgery, 70% of them are still alive, and that's with no surgery. And some of these patients probably died of heart attacks and strokes and other things. And if you look even further out at 10 years, you can see that even 10 years after surgery, more than 80% of these patients are still alive. And if these patients are getting diagnosed in their 60s and 70s, well, you know that patients at that age, they die of other causes. So not everyone who died in this study died from their cancer. So predicting survival in NET patients is challenging. And the survival numbers we see at large institutions don't necessarily reflect what we see in the country as a whole, and there are many reasons for that we talked about before. But one of them is that if you come to a large medical center, you might actually be in better health, you might be younger than the average person out there in the community. So here are a few rules of thumb I find helpful. So take this all with a grain of salt. These are not accurate numbers, but this works for me in the clinic and has done for a long time. So patients with localized low-grade NETs have an excellent prognosis after surgery. 10-year survival, typically more than 80%. Patients with metastatic advanced low-grade neuroendocrine tumors have a good prognosis, not as good as those above, with a 5-year survival, 40 to 60% maybe. So about half of them are alive 5 years from diagnosis. And that's actually pretty good for advanced cancer. Patients with localized, poorly differentiated neuroendocrine carcinoma can have a prolonged survival after regional therapy. but unfortunately, most will have their cancers come back within 2 years. Patients with metastatic, poorly differentiated neuroendocrine carcinomas have a short life expectancy in general, typically median overall survival less than a year, and unfortunately, less than 20% of them are alive beyond 2 years from diagnosis. So let's talk about grade 3 neuroendocrine tumor or neuroendocrine carcinoma therapy, the aggressive, poorly differentiated tumors. Most of them, unfortunately, will come back after surgery. We give radiation therapy and chemotherapy with surgery, but we don't know how much it helps. I think it helps, but I just can't tell you how much it helps. So the overall survival of patients with advanced metastatic grade 3 neuroendocrine carcinoma, as I said, was less than a year. And the available treatments are not very good. So a combination of a drug called carboplatin or cisplatin with a drug called etoposide is a typical first-line choice. And then we should always look at clinical trials if possible. And the grade 3 neuroendocrine carcinomas can be very lethal. So refractory grade 3 neuroendocrine carcinomas after initial therapy are incredibly hard to treat. So this is a study we conducted at Mayo Clinic, and we looked at the second-line therapy. So after patients have had growing disease on first-line platinum and etoposide therapy. And unfortunately, I just see now that the numbers on the graphs on the right-hand side have actually are wrong. They have flipped. But if you look at the median progression-free survival, which is actually the lower graph, it's only 2.3 months. And there is no chemotherapy that's better than another. As for the median overall survival, it's only 6.2 months. And it doesn't seem like one chemotherapy is better than another. So this is an incredibly challenging disease to treat, and we desperately need better treatments. And immunotherapy is being looked at and looks somewhat promising, and a lot of other things are being explored. Finally, I just wanted to mention a few things of end-of-life care of patients with neuroendocrine neoplasms and the cause of death. So this is not well studied. Many patients with low-grade neuroendocrine tumors don't die from their cancer. They die of what I say sometimes natural causes, old age and other things. And that's common in the grade 1, grade 2 neuroendocrine tumors. With metastatic disease, the tumor itself is usually the cause of death eventually, and we have studied that among others, and we have some data coming forth on that. As for those with extensive disease, liver failure from tumors extensively replacing the liver is fairly common. It's a gradual process, often pain-free. Patients just lose energy, appetite, and sort of slowly fade away. Bowel obstruction, unfortunately, is still fairly common and can result in wasting, losing weight, muscle mass, and death of just being weak and prone to infections. And then there are other complications. Blood clots can be sudden and lethal. Complications of metastases, such as brain metastases and spine metastases, are seen in patients with high-grade tumors with some frequency, and then infections, as I briefly mentioned before. So as for palliative care in patients with neuroendocrine neoplasms, I think we should refer patients as they get closer to the end of life, and especially if they have symptoms. But we should probably refer patients with burdensome, troublesome symptoms to palliative medicine, because in some other cancers, it's actually been shown to prolong survival and improve quality of life. And then we often do what's called co-management. The patients see palliative medicine for management of their symptoms, pain, lack of appetite, nausea, things of that nature, and I see them in the oncology clinic for management of the actual tumor. And then as things get closer to the end of life, transition to hospice care is very appropriate, and we probably should do that sooner than we often do. So that brings me to the end of the discussion. I, again, very much thank you for allowing me to present.